this computer there. So I am so pleased to introduce Dr. Wayne McCormick. He's a professor and he's actually the head of the Division of Gerontology and Geriatric Medicine at Harborview Medical Center and the Department of Medicine. He is also the William E. Colson Endowed Chair in Gerontology. He's board certified in internal medicine, geriatric medicine, hospice and palliative medicine, public health and general preventive medicine. His research interests are in epidemiology and health services use of seriously ill patients, and he is the current and founding medical director of Bailey Boucher House, which is an AIDS long-term care facility and day health center. And he directs the Palliative Medicine Fellowship at UW. If you wonder how he finds time to do something like this, all I can say is we're very grateful because he's got tremendous expertise in palliative medicine and POLST forms. So take it away, Dr. McCormick.
Okay, thanks, Barb, and thank you all for being on. I don't know how it is where you are, but Barb and I are enjoying a bright sunny day with in the low 60s. Daffodils are up, tulips are up, lilacs are coming out, and the rhododendrons are blooming. So I don't feel hunkered down at all. I'm ready for springtime. So we're going to talk about the POLST form today and 3 decades of work. 3 decades isn't that long in the history of medicine. And the POLST form has come a long way. Nationwide, and advanced directives have come a long way internationally. The POLST form is being used in Europe, in Southern Asia, not so much in Eastern Asia, but time will tell. So we'll kind of go over the history and research of the POLST form. And I'm going to spend the first period here talking about the background of the POLST and where we've come from a research standpoint. So here's our roadmap for today. We'll talk about the POLST form in the context of advanced care planning generally, because the POLST form is basically a glorified advanced directive for persons to tell everyone around, including providers, what they want done if and when they become seriously ill. The addition of the physician order for life-sustaining treatment, otherwise known as POLST, is a way to perhaps an attempt to increase the adherence of others to that advanced directive. I've been a physician for a long time, and I'm not overly impressed by how everyone jumps to follow my orders for this and that. Nevertheless, to the extent the physician order or advanced practice nurses order for us to pay attention to someone's advanced directives, maybe carries a little bit of weight and adds some oomph to adherence with their advanced directive. So we'll talk about that some and go over the research. Then I'm going to present you a bunch of cases. And there's maybe a dozen of them. I want you all to get ready for the cases. And by that, I mean, maybe have a piece of paper and a pencil handy so you can write down the number of the case and a question or concern or rebuttal that you might want to put in the chat to Barb about the case. I'm not going to be paying much attention to the chat box or the Q&A box due to my inability to multitask. So I want you all to go ahead and put comments in there, and then we'll go back to the number of the cases, and Barb will cue me to address your concerns during the end of the talk. So just get a little something so you can keep records when we get to the cases. Thank you. So the POLST form largely came from a gang in Oregon, but there were plenty of collaborators elsewhere in the country, in Boston and Massachusetts, California, and elsewhere, to put together this physician order. And it's been 3 decades. It was in the 90s when the POLST form first developed. Elsewhere in the country, it was called something else. Physician order for life-sustaining therapy, or physician's order for sustaining therapy or supportive therapy. Medical order for life-sustaining therapy, medical order for supportive therapy, all means the same thing. It's an order to pay attention to an advance directive. So the gang in Oregon put together a task force in '91, and they thought they had a bunch of good ideas at the time. The first idea, of course, was making it a physician's order, because advance directives already existed. Living wills have been around for 3/4 of a century or so. But they decided to make it a brightly colored order form. Some of them, some of the early ones were pink and green. Some of them were yellow and orange. So just to attract the eye was the idea. And the other idea was that the POLST form was most useful when the answer to the surprise question was no. You all know what the surprise question is. It's largely used in palliative care and in ICUs, and that is, it's a prognostic exercise. You ask the question in the patient that you're talking about, would you be surprised if this person died in the next 6 months, or whatever interview you choose? And it's pretty amazing how ill people are who come into hospitals and nursing homes these days. I do an exercise with my residents when I'm attending in the hospital at Harborview. And usually we have like maybe 12.5 patients on our team, 18 people or so. And we do the surprise question through the whole list, run all 18. And it's tried and true. Every time we do this, and I attend 3 or 4 times a year, every time we run that list, about 2/3 of the patients, the residents say they would not be surprised if the person died in the next 6 months. It's a tribute to how ill people are in the hospital. And then we run the list again, and the question is, would you be surprised if this patient died next week? And usually 1 or 2, they would not be surprised. And that's a stimulus to think about hospice and those kinds of things. Every other time that results in a hospice referral, somebody going home on hospice. So anyway, that's the idea. A POLST form should be considered in that kind of scenario. And that's why a lot of nursing homes and hospitals have largely decided to try to have a POLST form on just about everybody who comes in. In most of WWAMI, it can be signed by a physician or a nurse practitioner, and in some cases, a physician assistant. And it turns patient preferences and advance directives into orders. The idea being increasing the likelihood that those wishes would be honored. It is a kind of a living will with an order. Living wills largely are filled out when people are pretty healthy, though. And they're usually fairly not very specific to any particular circumstance. It's a clear statement, and it's a useful thing to have. But you need to know where the thing is, if it actually exists. And often it requires a fair amount of interpretation. But it's still really useful, a living will, because it indicates that the individual thought about it enough to complete that document. I think that's a good indicator. And in a way, it gives the provider a little bit of largesse to try to channel that individual and think about them carefully with regards to what they want done if they're really seriously ill. So they have value. The POLST form is that plus the physician's order. So it is for people who are seriously ill. There are specific, much more specific options presented on the POLST form with boxes to be checked. The patient keeps it, and the physician orders the patient and physician or other provider signs the thing. The usual approach for most patients is, if they're in a nursing home or hospital, it belongs in their medical record or chart, scanned into the electronic record or placed in the hard copy record. If they're at home or in assisted living or some circumstance like that, most people either put it on the refrigerator door or on the back of the front door, some prominent place where anybody comes in can see it. It makes me think of a guy named Len Cobb. Dr. Cobb was one of the originators of the CPR program here in Seattle half a century ago. And Len kept his POLST form hanging out of his pocket wherever he went. So I'm not sure he's still with us. But in any case, so the idea is to have it prominent, visible, and useful when the time comes that it's needed. So it's a medical order. The targeted population is people who are seriously ill. A surrogate can also sign it. It doesn't have to be the patient. It can be a durable power of attorney or legal surrogate next of kin if the patient's not able to sign it for some reason. It specifies for full or limited treatments, CPR or not, and the do not attempt resuscitation part, I like the language used in it. It's do not attempt CPR, but then followed by allow natural death. I wish they'd flip-flop those, because allow natural death, I mean, that's what we're gonna do for you, as opposed to do not attempt resuscitation. That's what we're not gonna do for you. So I like to use allow natural death when I'm discussing it with patients, because I think it's, first of all, it's just more humane, and I think more palatable to most people. There's other orders on the POLST form. The adherence with other orders gets a little squishy and less than the resuscitation or not. The adherence to that's become pretty darn good, which I'm about to tell you about. So it helps patients get care aligned with their values and goals in the best of circumstances. It's known to increase patient and family satisfaction with care because they're empowered. It's associated with decreased unwanted ICU care and earlier hospice enrollment. It helps discuss goals of care, helps inspire those conversations, which is good. I often like to say, look, let's leave this an open conversation. This doesn't have to be the last word. So it can inspire ongoing conversations as patients' conditions change. So in large part, it's a useful engine of advancing adherence to what people actually want, especially as those wants and needs change over time. What's a bad idea is to just hand somebody a POLST form and say, here, fill this out and we'll both sign it. Not so good. You actually want to start by not talking about the POLST form, is my advice. I think it's good to sit down and get an eye level with somebody if they're in the hospital or in bed, nursing home or at home. And tell them you're about to talk about something that's pretty important. So really need our mutual attention here. So we can make sure you're getting the care you actually want, what's best for you. Goals of care is our talk, doctor talk. It's medical jargon. So it's more about saying, I want to make sure that you're getting the best care. What's really important to you is what we want to get at. What are you hoping for? Have you ever taken care of somebody who was really sick before? And tell me about that. What are you worried about with your current illness? What makes life really worth living for you? What do you do that you really like these days? What did you used to do that was really your thing? If you were to get really a lot sicker, what would be most important then? Tell me about that. So this is the way I start before I even bring up the POLST form. Then it leads into discussion about what they actually might want. And, you know, after you get the answers to these questions, you might decide, you know what, it's not the right time to be talking about the kinds of things they might want or not want on the POLST form. Let's just leave this an open conversation and come back to it later. Or it might lead right into that. You know, sometimes you start this conversation and the patient says, well, I've got this thing called a POLST form. Maybe that'd be useful to you. It's on the back of the front door. Didn't you see it when you came in? So every once in a while that happens because it's, you know, a lot of people know about POLST forms these days. But usually you need to go through these kinds of questions before you get to the POLST form itself. Especially if their condition is changing. And, you know, denial is a very human thing. People like to think of themselves as functional and well. But sometimes it's important to say, you know, I perceive that we're in a different place now. Your health has deteriorated a bit. Anyone in your situation might be worried about getting sicker, and I want you to know I'm going to be here for you. But I want to honor your wishes. So what are you hoping for? Sounds like you're hoping to get better control with your symptoms. Knowing what's important to you, I can make recommendations about how to proceed with your care. So going deeper is a good idea before you hit the POLST form. So here's Oregon's early POLST form. And you see right up front is the CPR decision. Resuscitate or not. And this was before they put on the allowed natural death part of things. I've noticed that a lot of nursing homes no longer have DNR on their charts or in their medical record. They only use allow natural death, which I like myself. I think we're kind of headed that direction. Appreciate hearing from others of you because I think semantics matter. Anyway, that resuscitation's right up front. And then medical interventions, the adherence to this is pretty good too. Comfort measures only, limited interventions, or full treatment. That's all doctor talk though, and nursing and doctor talk. That's not what people necessarily want. You know what's a problem, what I think is maybe a little bit of a nuance that should be changed is you notice there's no room on the darn form to write in what people actually say. What I'll often do is take that little part under B that says additional orders, and I'll just write verbatim what people say. I was about a month ago, I was with a woman and her son. She was in her late 80s, had pretty serious multimorbidity, and her son was with her. Son was a middle manager at Amazon. And so we were talking about the POLST form and advanced directives. I'd gotten a pretty good idea about her and her history and what she might want. She was a little cognitively impaired, had mild Alzheimer's disease. And so her son was talking with her about resuscitation and whatnot, and she wasn't really quite getting it. And I wasn't doing a very good job mediating the two of them. But finally, she just blurted out, look, if I'm dead, leave me that way. I thought, great, okay, that I can hang my hat on. So that's what I wrote under additional orders. If I'm dead, leave me that way. Meaning do not attempt resuscitation if she loses vital signs. That'd be good to be able to write a sentence or two. So I'd encourage you to do that. Just put it right in there or wherever you see a blank space with a star next to it. The antibiotics section has actually historically had very poor adherence. And the tube feeding piece, you know, actually there's some movement to remove the artificial nutrition part of things because, you know, why these days? It's become less and less useful as society's changed and as we've become more comfortable with discussing that kind of thing, interestingly. The back of the POLST form allows for some changes and signed by everybody. how to review it and change it in the future. Here's Washington's current one. Sorry, this looks a little fuzzy for some reason. You'll notice that there's not a nice box right up front where you can write a little something if you wanted up top there. But then there's the DNR, and it's not real visible, but allow natural death is there as well. And then the comfort measures only, limited interventions, and full treatment. So things are moving along. Bright green, day glow. Many of you have seen these or ones like it. Let's talk a little bit about the progression of research over the last 3 decades, where things started and where we are today. Things have changed a lot. In the early 90s, there was a lot of focus groups in various settings, showing that the POLST improved agreement with patient wishes often because you're actually talking about them. No surprise there. And POLSTs were really rolled out most aggressively in nursing homes, where adherence started out pretty good and got better over time. In this particular study, no nursing home residents with a POLST orders for DNR received CPR. And in this 2000 study, wishes were followed for CPR 91% of the time. Antibiotics, pretty good, 86% of the time. IV fluids and feeding tube, also pretty good. This is a little better than some other studies showing the antibiotic adherence was down around 60% or so, but that's okay. And then more recently, 96% of Oregon nursing homes were POLST guidelines decisions evolved to care standard, meaning everybody gets one. Some people who chose do not resuscitate wanted additional interventions because the resuscitation piece technically is if you lose all your vital signs. What if you're really super sick but have not lost your vital signs? So technically it's okay to be DNR, but to want some other interventions. And some people who want CPR then preferred some limitation or emphasis on comfort. So there's lots of different nuances, and we'll see these in some of the cases. Make some providers uncomfortable, but we got to be a little creative sometimes and understand the nuances here. That's why it's helpful if you can actually write down what people say, helps you interpret those kinds of things. EMTs these days pretty much universally look for and recognize POLST forms. That wasn't so good in the 90s and early 2000s. Now it's much better. And they'll change their modus operandi if they see a POLST form. And I think their interpretation of them has gotten much, much better over time. POLSTs agree with advanced directives, generally speaking. Again, no surprise there. And then about a decade ago, 94% of Oregon nursing homes report treatment consistent with POLST. 50% of DNR residents preferred some additional interventions. Again, some of these nuances coming out. 24% of people who wanted CPR prefer limitation or even comfort measures only. That happens. That can be a stimulus for more conversation or just buying into it and see what happens. Because really an infinite number of things can happen. There's lots and lots of ways things can go down. And that means that it will remain, to some extent, a matter of art to interpret the POLST forms in the setting of whatever you're presented with clinically. Most California hospitals now have POLST policies and forms and have educated staffs with high compliance. You know, one thing that's taken 3 decades to do is to get us to know all about POLST forms, advanced directives, and adhere to them. more and more emphasis on patient autonomy. That's an evolution. The amount of patient autonomy allowed has palpably increased over the past few decades, where it's not our game, it's their game. And we need to do what they suggest. That continues to evolve. There's lots of stuff in the news these days about patients owning their medical record and making sure that our medical notes and documentation are written in such a way that patients, when they look at them, can understand them and not disagree with them. No doubt a very healthy development, but that makes some providers uncomfortable. But I bet you towards the end of this decade, it'll just be part of the woodwork and people will be very comfortable with that. And this is just part of that same evolution. Us knowing about advanced directives, knowing about POLST forms, and adhering to them. But to adhere to them, we got to understand the nuances of them and be artistic about it sometimes. So let's summarize 3 decades worth of research here. There's gradually improved adherence to POLST forms by everybody, by EMTs, by nursing home staff, by hospital staff, by emergency room staff. You get the idea, by everybody. Skilled nursing facilities, by and large, now use them very widely and almost require every resident to have a POLST form. It's become the advanced directive. And it's like, what's wrong with you? You don't have a POLST form? So they pretty much make sure everyone has them and won't necessarily recognize another directive. An interesting development that may have some pros and cons. Let's think about that when we go through our cases. So EMTs recognize and adhere to POLST. The validity and reliability of the forms improves across states. So in other words, states have come around to using them roughly as well as Oregon does. I mean, Oregon had a head start on everybody, but Virginia, Massachusetts, New Hampshire, Arkansas, California, basically all use something like the POLST or the POLST pretty darn close to the same way. So that's kind of interesting too, that it's pervaded the country and everybody's doing roughly the same thing. So for those of you who are in Arkansas right now or elsewhere in the country, your practice around POLST forms probably isn't that different than somebody in Portland. An interesting development. But now that we're halfway through the hour, it's time to look at some cases. And please do take notes or write in the chat or Q&A. The POLST looks kind of like a cookbook, like a recipe. Can we really cookbook the advanced directive 100%? Well, the way I'm asking that, you know the answer. No, you can't really cookbook it per se. It's always going to be subject to interpretation. What's remarkable is how often it's a slam dunk. These days, a lot of times the POLST form is fine. I mean, somebody's got a very serious illness. They and their loved ones can verbalize that they do not want to resuscitated. They want to be allowed to die naturally, and you want them to really concentrate on their comfort. And everybody can get on board with that for a number of very serious illnesses, and there's no contention whatsoever. So what's remarkable is how often it works out just fine. And it works out just fine too when people have chosen CPR and full treatment. That's okay. At least we know. We know what to do now. Let's just do it. That can change. We can keep the conversation open. But for now, we know what to do. So we recognize it and adhere to it, even if we don't necessarily think it's something we might choose if we had the patient's illness. That's okay. That's kind of not what counts. It's okay to take that into account and to include it in future conversations if there's time. But we know what a POLST form is, and we are much better at adhering to it than we were 1 or 2 or 3 decades ago. That said, we have to explore some nuances of the POLST form. So let's talk about some cases. I'm going to present these cases, and then I'm going to give you a minute to think about them and write things down if you have questions. These are all real cases, and I can tell you how things turned out and will along the way. So here's case 1. This is from a few years ago, but not that long ago. 90-year-old man with advanced renal failure who had been on dialysis for a couple of years, also had fairly advanced cognitive impairment, but he had excellent interpersonal and interactive skills, so he could hide it pretty well, but really he couldn't remember what happened yesterday. Had a history of alcoholism, so his dementing illness was multifactorial. It was probably Alzheimer's plus alcoholism, maybe plus vascular, because he did have severe coronary artery disease and peripheral vascular disease. He was admitted to the hospital with pneumonia, having been sent from the dialysis center, where he's febrile, sweaty, and short of breath on dialysis. They packed him up and sent him to the ER. And the kidney center was keeping POLST forms on everybody who had them. And their POLST form said DNR, but full treatment. So he did not want to be resuscitated, but he did want full treatment. This fellow currently has vital signs, and he's really sick with pneumonia, dialysis. Does that cohere, being no code, but full treatment? I'll give you a minute to think about that. Write down your thoughts, how you would proceed. You're in the ER, and you're going to decide what to do with this fellow. Okay. Let you think about that one for a minute. Let's talk about another one. Here's case 2. Younger woman, 58 years old, with metastatic lung cancer. She was on hospice and had been on hospice for about a month. Doing fine. She had a very large multi-generational family who actually were quite attentive. She had daughters and grandchildren taking care of her at home with the hospice team. Hospices are big on POLST forms too. They really like them. But not everybody on hospice has to be no code. About 5% of patients on our hospices here in the Seattle metro area do not resuscitate. They use CPR. Now, that's a subject of ongoing conversation for those people who are on hospice. But nevertheless, you can be on hospice and be full code. That is legal. In fact, the hospice must serve you regardless of your code status if you meet eligibility criteria. So she was full code, but comfort measures only. And her family were very supportive of them. So she's not in the hospital. She's at home on hospice. Now you're the hospice worker, hospice nurse, or social worker. Think about that for a minute and see how you would imagine that evolve. Are you comfortable with that? Feel okay about that since you're going to be in the home fairly frequently? How would you engage with the family and the patient in keeping that on the side burner and keeping it an open conversation? I'd appreciate your thoughts on that. Think about that one for a minute. Great. Okay. Let me tell you about another one. Here's case 3, a 62-year-old woman with advanced liver failure, end-stage liver failure from hepatitis C virus and alcoholism, bad combination, continuing to drink fairly heavily. She arrives in the ER hypotensive and encephalopathic, so she's completely out of it, delirious and encephalopathic. The hospital actually has a POLST form on her from a time before, and she is do not resuscitate and comfort measures only, but it's only signed by the physician, and you can't read their signature. Has not been signed by the patient nor any surrogate. You're not sure a surrogate actually exists. So this is in the medical record of your hospital in the ER, but you don't know who this was who signed it. And it's not signed by the patient or surrogate. And the patient can't really tell you much right now. They're hypotensive and encephalopathic from their end-stage liver disease. Now what? Ponder that for a minute. Think about what you might do, how you might care for this person in the ER. Bit of a conundrum. At least you got a POLST form, but is it worth anything, or is it just throwing you off track? Hard to say. Give me your thoughts on that one. Let's do another one. Hope this is working for everybody. Let's keep going. Here's an 88-year-old man with advanced emphysema, COPD, and heart failure, and moderate Alzheimer's disease. He comes into the ER too with severe shortness of breath, really quite short of breath, pretty uncomfortable. Has a POLST form, says DNR comfort measures only, signed by the patient and his physician. Physician's not present. Patient is, but he's got pretty advanced dementia. His daughters are with him in the ER. They're both lawyers. They demand full treatment and CPR, stating that, maybe they see the POLST form, but they say, that can't possibly be right. That's not him. He wouldn't say that. And they want CPR. They want everything done. They just don't believe that POLST form. And they are his legal surrogates. He only has 2 daughters. That's the situation. You can see that this is uncomfortable situation here. What should we do about this one? All right. Ponder that. These are conundrums, huh?
Let me know if you want me to chime in with some comments.
What do you think, Barb?
So, well, I can go back to some previous cases if you want.
Yeah, let's break in, because I got a bunch more.
All right. So for case number 2, CPR means a trip to the hospital to call it. And Judy said she wouldn't feel comfortable deciding when to stop. Does CPR really mean full code and associated interventions to the patient and family?
Yeah, CPR means CPR, right? We all learn it, basic life support, pumping on the chest, giving respirations, calling EMT, calling the ambulance. That's what it means to a hospice worker.
And then Judy also said, is this consistent if a healthcare provider isn't present? Do they expect CPR if the on-call nurse arrives?
Yeah, they do. But this case, I'll tell you what, this case worked out fine, I was a hospice medical director for Providence Hospice between 2004 and 2014. This came from back then. This was a terrific family. They were just wonderful people. And as the patient continued to deteriorate, her lung cancer was widely metastatic to bone, liver, brain, everywhere. And she deteriorated somewhat slowly and linearly over a period of about 2 weeks. And during the last week, she really wasn't very interactive. But what was remarkable is how little suffering she experienced. She wasn't really short of breath per se. She wasn't bothered by her brain metastases much. It didn't seem like she was in very much pain. And her children were unanimous in saying, look, she's really not suffering. She's going so peacefully. Let's just let nature take its course. And at that point, they were her surrogate decision makers. So they circumvented the CPR idea based on their knowledge and love for their mom, which the feeling for the hospice team was, this is the right thing for this patient at this time, to just concentrate on her comfort. And thankfully, they didn't have to do much of anything. You know, that sends me off on another tangent. Everybody thinks dying is painful. You know, often not so much. About 15% of everybody on hospice gets a comfort kit, which is doses of morphine, Ativan, some bowel meds, some Haldol. About 15% of comfort kits are never opened or used. Now, those patients might have some of their own meds. Another substantial amount are opened, but the contents aren't used. So I'm not sure dying's always all that painful. Once in a while, it's a pain challenge, but often it's pretty easy to manage. Certainly wasn't her case.
So there's another question. So you kind of answered the question about METs to the ribs, but another question came in for this case. How would CPR work with lung cancer? And this person qualified that they're not a provider. So
sure. Well, it would be CPR seems harmful to those performing it. In other words, me as a medical provider, when I'm doing CPR, I'm mindful every time that if that person was awake, it would hurt. It would be very uncomfortable to be receiving CPR. It is life-saving in some situations, generally not in advanced cancer, but it would be pretty uncomfortable. What's remarkable about POLST forms is we currently in the hospital and elsewhere recognize them, even knowing that we feel we might be hurting this person. If they've truly lost all vital signs, they're not going to feel anything. But even if they feel it, it is their directive, and you are serving them by honoring their directive. So yes, it'd be unpleasant to deliver it. It wouldn't necessarily be unpleasant to be receiving it, but it's that's the way it is.
now, if you want to go back to number 1, Lorraine indicated the possibility of treating the acute issue since the patient said to do this on the form.
You betcha. That's the way this one turned out, right? What happened is he was admitted to the hospital. His pneumonia actually was relatively easy to treat. He was a little volume up, so they took off a little volume with his dialysis, treated his pneumonia with simple antibiotics, and he was fine. He didn't ever lose his vital signs and therefore didn't need to be not resuscitated. So it worked out just fine to just go ahead and honor the full treatment part. It's okay. DNR is for when you are dead, when you lose your vital signs. He did not.
Do you mind going forward to case number 3? And we have a comment about, can you consult with the family? Does the patient have a POA or DPOA who can provide input? Or can you look at the date on the POLST and check the patient's medical records to see if she's had a medical appointment that day to try to track down the provider?
All great ideas. That's terrific thinking. And that's creative thinking around how to use this POLST form. What happened in this particular case is the patient received IV fluids, lactulose, and actually perked up over a day and got a little bit better and much more with it. And then the team taking care of her showed her the POLST form and said, "This looks like what, have you ever seen this thing before?" She said, "Oh yeah, yeah, that's what I want. That's okay." I said, "Well, you need to sign it because, otherwise we didn't know what to do." So like case one, this one turned out fine because you just went ahead and treated the person and they got a little bit better. So you could actually carry on with the conversation and legitimize their wishes. But the doc should have figured out before to have the patient sign it. That's not so good.
So then moving on to case 4. This is fun.
Yeah.
So Mary Zeitner suggested calling in the ethics team and probably alerting risk management.
Yeah, that's thanks, Mary. That's pulling a couple of big triggers. Totally legit to do that. The ER docs in this case said, "Look, usually we can treat COPD and CHF. Let's just see if he gets a little bit better and see if we can address this conversation more. Right now, what we're going to do is treat his emphysema and his CHF, see if we can get it some better." They, of course, were totally on board with that. That's great. So they did. And he did get quite a bit better from the standpoint of his shortness of breath, because COPD and CHF is pretty easy to treat.
Yeah.
And it gave them time to talk more about it. And he actually did get a palliative care consult to sit down with the daughters and talk about the likelihood that CPR would be helpful to somebody with advanced dementia, COPD, and CHF, and that if he had got short of breath again, we would do the same thing again. We'd treat a COPD and CHF because that's what comfort is all about. He's uncomfortable with his shortness of breath. He wants comfort measures. Let's give him some comfort measures by treating his COPD and CHF. They were fine with that after they learned more about whether CPR would actually work or not in his case. And that it's perfectly okay to treat the other stuff because it's addressing his comfort.
So not necessarily knowing all of that, Lorraine was making the point that what sometimes often happens usually is that if the kids want stuff done, it doesn't matter what the patient decided.
That can certainly happen. If you've got some very aggressive surrogate decision makers, and if they are the legal surrogate decision makers, then that's true. They stand in the shoes of the patient and make decisions for them, technically. But that's always, to me, a stimulus for, let's sit down and have a conversation about this. Let's talk about it. Because we're on your side and we want to do what you feel is right. Let's think about all the nuances around that for your dad or mom or whatever. Sometimes that, every once in a while that continues in contention, but usually not. Once you befriend somebody and they get the feeling that you do give a darn about them and their loved one.
Okay.
Okay, let's keep going. Let's see, did we do this one? No. Here's a 58-year-old guy, again with liver failure. And he is, he's got a couple of POLST forms. One's a few years old that said, do not resuscitate, comfort measures only. And then he was admitted to a nursing home because his disease had progressed. And their POLST form said CPR full treatment. So you got competing POLST forms here. Think about that one. Write down a thought or two, and we'll talk about it in a minute. Here's a 57-year-old man with advanced pancreatic cancer, and his post form said, do not resuscitate, but full treatment. He arrives in the ER after a suicide attempt with a gunshot wound to the head. He was intubated in the field due to suicide. We'll talk about that one in a minute. Super sad situation here. Okay, 92-year-old man with Lou Gehrig's disease, ALS, and with cognitive impairment arrives in the ER with pneumonia, hypotension, and unresponsive. His post form says full code, full treatment, but it's 6 years ago. His son, who's his power of attorney, is present and says, just keep him comfortable, let him go. Comfortable with that? Think about it, jot down your thoughts. Here's a fresh one. This is just from a week and a half ago. 72-year-old woman in the nursing home has advanced obesity, hypoventilation syndrome, sleep apnea, severe CHF, restrictive lung disease, in the setting of longstanding HIV infection. And she has a long history of schizophrenia and is pretty advanced cognitive impairment with a MoCA of 15 out of 30. Cannot read. She has no post form. Her only living relative is a niece, which would not be on our list of default surrogate decision makers in Washington state. She was full code when she was in the hospital, and now is the same in the nursing home. And when asked about her goals of care, she said, well, I want to be allowed to die naturally. And when it's my time, it's my time. But when shown a POLST form to sign, she gets agitated and just won't engage further. Again, she can't read, so she just doesn't like forms. The nursing home, though, requires a POLST form on each resident. So what do we do here? What should her code status be? And here's a 72-year-old with advanced Parkinson's disease, dense right hemiparesis from a stroke, aphasia, and hypotensive. He's DNR, comfort measures only, signed by the patient and surrogate decision maker, but no physician signature. Sound okay? I have another one actually just from last week, kind of like this, where a fellow came in with a stroke patient came in to Harborview. He's in his 80s, really depressed level of consciousness, dense right hemiparesis too, and aphasic. And his POLST form had the do not resuscitate checked only and nothing else checked, signed by him only. So really similar case.
So Carol is indicating, and I'm going to leap to an assumption that she means the one you just mentioned as well, that they need an MD signature on those POLST forms.
Everybody agree? Any naysayers to Carol? Or Carol, have you changed your mind? Well, I bet you among those convened here tonight, there might be different sentiments about that. If the patient signed this, it's not a POLST, is it? It's not a physician's order for life-sustaining therapy. But what would you say if I said this is an advanced directive?
And I think someone has agreed with you that they said that they would just say it's the patient's choice.
Advanced directive. This is, here we are in the art of the interpretation of POLST forms and advanced directives. And we're not there, right? We're just looking at a slide. But if you're physically present and can and see the sun and conversing with the son and getting a judgment about that individual, their trustworthiness, their level of love for their dad, or their secondary gain, or what, any of the 9 million things that might cross your mind in making your decision. We're all human beings. Those things will influence you about whether you go with this as an advanced directive or say, I can't follow this.
So there's
Now,
a question that says, doesn't the advance directive have to be signed by a witness?
there again, we're in the art realm of interpretations. Usually an advance directive does have to be signed by a witness. Yeah. Or two. But here we are, here, this is all we got right here. So you have to make a judgment about it. I imagine, there's a bunch of us on this call here. Some of us might judge it one way, others another way. But this can come up. It's come up for me a few times. You're going to see this kind of thing. Hardly a cookbook.
So do you want to go back to case 5?
Sure.
One suggestion is, oops.
Going the wrong way here. Bear with me. Go ahead, Barb.
One suggestion is to check the dates on the forms and use the most current one. And that was echoed by someone else who said, doesn't the 2013 POLST override the outdated one? And if not, why?
You would think so, but you might want to dig into this one a little bit. Some of you may work in the skilled nursing homes. I've spent a lot of time in various nursing homes. I was in one this morning because I'm medical director at Bailey Boucher. And you might know that most of the, being admitted to a nursing home is a big deal. It's kind of like buying a house. You sign a whole bunch of forms. The admissions coordinators of nursing homes are usually wonderful people with outstanding interactive skills. They may not be medical professionals, though. They may or may not be a nurse or other provider. They might just be a very talented person with good interactive skills. And often it falls to them to make the first cut at a POLST form, because you choose, you sign a bunch of financial forms. You choose your nursing home when you enter you choose your funeral home when you enter a nursing home, and POLSTs often come up then. And it may or may not be a skilled interaction, especially in the setting of signing all these other forms to figure that out. So you'd want to call around. You'd want to find another surrogate decision maker to see which one of these forms you could follow, depending on how much time you have. And in this kind of situation, the person's mildly encephalopathic, but conversational and sleepy. Maybe with a little therapy, they'd wake up like that other patient I had and be able to talk to you about it and indicate which one of these they actually wanted. That's actually what happened in this case. It was like our other case where they got a little better and were able to indicate which one of these they actually wanted to go with. Normally, though, if that didn't happen, you would want to go with the most recently dated one, but keep it an open conversation.
Do you want to move on to number 7?
Okay.
So the question for this is, does a POLST expire?
No. But a POLST, like we talked about a minute ago, a POLST can occasionally be overridden by a legal surrogate. So if the son shows up and he's the durable power of attorney and says this, and again, we're all just looking at a slide here. If you're physically present and you see your patient with unquestionably a life-ending illness, right? There's no doubt about that. Who seems comfortable in spite of having pneumonia, hypotension, and being unresponsive. And the son, having been perhaps on this journey with his dad for the past 6 years, says, this is the time. Let him go. Keep him comfortable, but let him go. And your interaction is one of trust and love and sacrifice. You may well be inspired to go along with it, but this is the human art realm of interpreting POLST forms, which is our ilk.
So with number 8, there's just a general question about why can't the niece be the decision maker in Washington?
Well, the hierarchy of decision makers, this is a matter of state law. The hierarchy in Washington state, and by the way, this is different in every state of the union. Some of them have similar identical, but you check with whatever state you're in because it varies. In Washington state, it goes, the patient, of course, is top, and then a guardian, if one exists, then durable power of attorney, then spouse, then children, then parents, then siblings. That's the hierarchy of decision making. So parents trump siblings, children trump parents. Recently, I believe that it was added to the bottom, close personal friends, which is actually how Oregon's reads. But it's different in every state, different in Idaho, different in Montana, different in Alaska. The niece would not be on that list currently. Now, under the current law, if you considered her a close personal friend, it might be fine. If the patient had assigned her durable power of attorney powers, that'd be great. And in this situation, this patient has no other friends or relatives than this niece, who obviously cares about her. So you'd want to interact with the niece. There's no reason not to take the niece's thoughts and wishes into account. But a good idea with all these cases is to aim for some form of consensus if you possibly can. What's going on with this particular patient is that she's reiterated these statements, and the next idea is to, in the niece's presence, now the niece is in Louisiana, so they'd be on FaceTime, a Zoom meeting or something. But in the niece's presence, the social worker, who's very skilled, was going to write down verbatim what the patient says, these exact quotes for her. So the niece can see and hear her auntie saying these things, and then have the patient sign it. It's not a POLST form. It's otherwise just a sheet of white paper with her statements on it. And they're going to try that and see how that goes.
And that corresponds with Lorraine's suggestion, which was to write this woman's words down and ask her to sign the statement.
There you go. That's what they're going to try to do.
Yeah.
We'll see how it goes. I'll give you all a report. Taken care of.
And Carol just mentioned that in Montana, most often a POLST is discussed with the patient and the physician in its creation.
That's good. That's the way it's supposed to be.
Yeah. So we're at the end of the comments for that.
Great. Okay. Well, I think that was a good exercise.
Yeah.
So I think you've seen that, the POLST form gives us the false impression that we can cookbook this stuff. And, sometimes we can, maybe most of the time. It's kind of a cookbook exercise, just not always. So you can see there remains room for the art of comprehensive communication and documentation of goals of care, POLST or no POLST. And again, things are changing. This is an evolving area. And there is a national POLST organization, which you can access via these websites. POLST.org is still an active website. And there's more and more research going on. In La Crosse, Wisconsin, it's become just a vogue. Everybody has a POLST form. La Crosse is a very homogeneous community. But they've had wonderful engagement and adherence around POLST forms. So once it becomes part of the woodwork like that, it's kind of interesting. And maybe that's where we're headed nationwide. Although I'm sure there'll be variability over time, in spite of the fact that now things seem to be moving towards more homogeneity. This is a big country. I'm told that POLST forms are pervasive in Canada and starting to be more and more pervasive in Mexico. So that's interesting. Great. Well, gosh, everybody, thanks for coming. How are we doing? Time-wise, I guess we're in pretty good
We're
shape
doing
here, Bob.
okay. We're at about 5:10. Just wanted to mention that Lorraine says Wyoming has these POLST forms as well.
Mm-hmm.
And Montana has end-of-life registry and advanced healthcare directives.
Wow, a registry. That's pretty good. Yeah. So things are moving, things are changing. Yeah. Any last comments, Barb, from the gang?
Well, let's see what we've got here. Montana also uses a POLST. And then Kim mentions that we've had some residents with COVID who were turned away at the hospital due to having a DNR comfort on their POLST. Can you comment on that?
Yeah. Well, that's rough. That's happened elsewhere in the country too. And we didn't. It got to be kind of old news and not newsworthy to some extent. But I know of physicians in some areas that were not that urban, where they simply could not take care of people. They did not have the space, the people, the nothing. They didn't have the morphine or Ativan to give people. And they just said, I'm sorry, we've got nothing. All we got is, we can bear witness, but that's about it. And that, there's been some deep scars created around the country by what people bore witness to. And I can only hope that they heal. But that certainly happened. I know that in some areas, like here at there's a guy named Daryl Owens who works at Northwest Hospital here in Seattle, and he had a protocol where he just show up when people came in the ER and coach them through advanced directives when they had advanced COVID. These are by and large people with a very advanced age and illness, and had some very good outcomes and good use, but they were resourced for that. Which is great. And the hospice organizations here have taken care of a ton of COVID patients at home and done a great job getting them through. Most of them were pretty easy to palliate, surprisingly enough. But I've also heard horrible stories. I have a colleague in Chicago where patients would come into the ER just screaming at them, saying there's, COVID doesn't exist and there's not, that's not what they have. And, they died right in front of them, denying that they had COVID, when you can be darn sure that's what they had. So there's just some really awful stuff has happened, but we just can't concentrate on that as a nation. We just got to keep trying to do better with this.
So Raven from Montana wondered whether the advanced directive needs to be changed every time their POLST gets updated.
Well, not necessarily. I think that if POLSTs exist, sometimes they kind of trump advanced directives. And advanced directives generally are very global and not necessarily directive per se in specific ways, whereas the POLST is much more specific and kind of provide medical talk. Whereas most advanced directives and living wills say things, if I'm in a serious medical condition, and there seems to be no hope, then it's okay to let me go. You know, it just doesn't make for specific medical choices or lay language.
And then Norma from Klickitat County has a very regionally specific question, which is for those folks who are on the Washington and Oregon border, do you need a POLST form from both states? They might have doctors in both states at times.
Sure. Well, you know, that's a judgment call. Kind of depends on the individual. It depends on just your relationship with that individual and what you believe their wishes are. This is where the conversation comes in. Don't rely so much on the piece of paper, but more what they tell you and what you hear. That could vary remarkably depending on the patient. I know it skirts around the answer, but I'm sticking to it.
So Ivan said that he's heard that the POLST contains medical orders and advanced directive, and that the advanced directive is a legal document. Can you speak to that idea where one's maybe medical orders and the other's a legal document?
Well, it's all technically a legal document, but legal in small caps. You know, it's regarded as a legally adherable document and directive. But you know, people, just like people don't follow my orders, people don't follow legal directives all the time either. The good news is, as a society, as a medical providing community, we're much better adhering to POLST forms than we were even a decade ago, and certainly better than 2 decades ago. So yes, while it is legal, since its legality is underpinned by the fact that people have to have a certain relationship to the patient to supersede the POLST that can only be dictated by law. So yes, they're legal, but I wouldn't, you know, I'm not sure it really helps our medical thinking to think about it that way.
So Wayne, how about if a POLST form contradicts what's stated in the advanced healthcare directive? Does one supersede the other, or is it just a date thing? Or
since the POLST form is much more specific and medical, it usually supersedes. Okay. But again, that's a stimulus for a conversation.
Yeah. And Mary Zeitner is wondering if PAs are allowed to complete the POLST these days. When it was first introduced in Washington, she's saying that PAs could not.
Yeah, that's true, but I think the law has actually changed fairly recently, like within either during 2020 or maybe early in 2021. I don't know specifically, but that merits looking into. Maybe somebody can Google it while we're talking.
Those are all the comments I have. If you had anything more that you wanted to cover.
I think that's it. I'm going to look that up right now. I bet somebody else is too.
Ivan says PAs can sign the POLST in Oregon.
Yeah, let's find out in Washington State. Yeah.
Oh, and we've got someone who's looking at a Washington form that says the backside of the 4/2021 POLST includes PA.
There you go. Okay. Yeah, it says that's now legal. Okay, I'm glad we cleared that up. Okay, gang, let's throw in the towel. Thanks so much for joining today. Let's go out and enjoy the sun and the rest of this evening.
Yeah, I think I speak for a lot of the chat that's coming in that they found this really helpful, particularly the interactive case studies and the opportunity to discuss those. Thanks so much, Dr. McCormick. Really appreciate it.
Yeah, it's a little more fun, but not a lot more fun when we're all actually present in a big room and we can chat and yell at each other about these cases.
Maybe more fun than being in the room when this is happening.
Yeah, right. Exactly. Well said, Barb. Thank you.
Yeah. All right. Thanks so much. Oh, let me see. I've just got one more Q&A here. Oh, okay. Thanks so much, Dr. McCormick.
All
And
right.
all of you next Tuesday.
Thanks, folks. See ya.
Bye.